Hello?
Yes.
Yes,
Hello?
sir. 3, 2, 1, start.
Okay. Good morning, everybody. So welcome once again to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a class on the newer and recent clinical trials in urology. So the presenter would be our resident, Dr. Karan, and moderator is our faculty, Dr. Somendra Bansal. So I would request Dr. Karan to kindly share his presentation.
Good morning, respected teachers. Today's topic of presentation is new trials in urology. First, about the trials on prostate cancer, it includes Taxinergy trial, Prosper trial, Profound trial, and Keynote 199 trial. Taxinergy trial was published in Journal of Clinical Oncology in 2023. Its objective was to assess the combination of cabzitaxel with radiotherapy versus radiotherapy alone in advanced prostate cancer. Primary endpoint was overall survival. Patients were randomized either to cabzitaxel plus radiotherapy or radiotherapy alone, and radiotherapy was administered for over 5 to 7 weeks. 500 patients were included, and confirmed diagnosis of metastatic castration-resistant prostate cancer were included. Overall survival was 30 months in combination group versus 24 months in radiotherapy alone group, and adverse events were grade 3 or higher. Adverse events were reported in combination group. Thus, combining chemotherapy with radiotherapy may enhance survival in advanced cases, but it warrants further investigation. Prosper trial was published in 2021. It randomized patients in 2:1 ratio to receive enzalutamide or placebo. Inclusion criteria were patients with non-metastatic castration-resistant prostate cancer, and total 1,400 patients were taken. Experimental group enzalutamide 160 mg was given orally once a day, and control group was given placebo. Primary endpoint was radiographic progression-free survival. It was seen as 36.6 months in enzalutamide group and 14.7 months in placebo groups. And time to first skeletal related event was significantly delayed in enzalutamide group. Thus, this trial established enzalutamide as a standard of care for men with non-metastatic castration-resistant prostate cancer. Profound trial was published in 2021. It stratified patients based on type of mutation, BRCA1, BRCA2, or other genes, and prior treatment. The patients 18 years or older with metastatic castration-resistant prostate cancer and confirmed to have mutations in BRCA1 or 2 genes were included. Total 387 patients were included, and olaparib 300 mg twice daily was given to the patients. And in control group, either abiraterone or enzalutamide was given. Primary endpoint was radiographic progression-free survival. It was seen, results were seen in olaparib group at 5.8 months and control group 3.5 months. And overall response rate was 33% in olaparib group versus 2% in control group. Thus, it demonstrated that olaparib is effective for metastatic castration-resistant prostate patients with specific genetic mutations. Our limitation of study was that it focused specifically on genetic mutations, which limits the application to broader population. Keynote trial was published in 2022. Patients were treated based on previous therapy for metastatic castration-resistant prostate cancer. Patients 18 years or older with metastatic castration-resistant prostate cancer who had progressed after treatment were included, and they were given pembrolizumab 200 mg IV every 3 weeks, and overall response rate was the primary endpoint. It was high in 11% in pembrolizumab group and 5.8% in control group. Disease control rate was approximately 30%, and median duration of response was 8 months for those who had responded. Thus, it highlighted the potential of pembrolizumab as treatment option for metastatic castration-resistant prostate cancer. Trials on bladder cancer, SWOG S1 314 trial, Nabucco trial, Invictus trial, and Keynote 057 trial. SWOG S1 314 trial, its objective was to investigate long-term outcomes of neoadjuvant chemotherapy followed by radical cystectomy. Primary endpoint was overall survival. Intervention was neoadjuvant chemotherapy, gemcitabine, and cisplatin, followed by radical cystectomy versus radical cystectomy alone. Sample size was 400 patients, and patients with muscle-invasive bladder cancer were included, those who had no previous treatment. Overall survival with chemotherapy group showed a 65% versus 50% in cystectomy only group, and disease-free survival rates were significantly lower in neoadjuvant group. And adverse events were well tolerated by the patients. Thus, it reinforces the role of neoadjuvant chemotherapy as an effective strategy in muscle-invasive bladder cancer. Nabucco trial, it was to assess the efficacy of nivolumab combined with chemotherapy for advanced urothelial carcinoma. Primary endpoint was overall survival rate, and secondary endpoints were objective response rate and progression-free survival. Nivolumab 3 mg per kg every 2 weeks plus chemotherapy, cisplatin or carboplatin versus chemotherapy alone. 800 patients were taken in the trial, and inclusion criteria was previously untreated advanced urothelial cancer patients. Median overall survival was 24 months in combination arm versus 18 months in chemotherapy alone group. Overall response rate was 50% in combination group compared to 30%. And adverse events were comparable in both groups. Thus, it supports the use of nivolumab in combination with chemotherapy as a first-line treatment. Invictus trial, it was published in 2023. Its objective was to evaluate the efficacy and safety of avelumab in combination with chemotherapy in muscle-invasive bladder cancers. Inclusion criteria was patients with untreated muscle-invasive bladder cancer, and total 300 patients were included. In the experimental group, avelumab combined with gemcitabine and cisplatin was administered in cycles as per the standard chemotherapy protocols, and pathological complete response rate after neoadjuvant chemotherapy was checked. It was achieved in 50% patients, indicating effective response to combination therapy, and adverse effects were comparable to those seen with chemotherapy alone. Thus, this trial suggested that combining avelumab with standard chemotherapy could enhance response rates in muscle-invasive bladder cancer. Keynote 057 trial. It was published in 2021. In this, patients received 1:1 ratio of pembrolizumab or standard surveillance. Inclusion criteria was patients older than 18 years old with high-risk non-muscle invasive bladder cancer who were BCG unresponsive. And patients received pembrolizumab 200 mg intravenously every 3 weeks until disease progression or unacceptable toxicity. And primary endpoint was complete response rate at 3 months. 41% patients achieved the complete response rate, and duration of response was 16.2 months, with some patients maintaining over the 6th year. Most common adverse events were fatigue, rash, and immune-related events like pneumonitis. Thus, this trial established pembrolizumab as potential treatment option for BCG unresponsive non-muscle invasive bladder cancer patients. Renal cell carcinoma probe and checkmate 9-year trial. Probe trial was to compare pembrolizumab plus exitinib versus sunitinib in untreated renal cell carcinoma patients. Pembrolizumab 200 mg every 3 weeks plus exitinib 5 mg twice daily versus sunitinib 50 mg daily for 2 weeks. Primary endpoint was progression-free survival, and secondary endpoints were overall survival, response rates, and safety profiles. 1,000 patients were included, and patients with clear cell RCC with no prior therapy were included. Progression-free survival in combination group was 24 months compared to 15 months of sunitinib, and response rate was significantly higher in combination group. And adverse events were manageable toxicities like hypertension. Thus, this trial supports pembrolizumab versus exitinib as first-line treatment for advanced RCC. Checkmate 9-year trial published in 2021. It was to evaluate the efficacy and safety of nivolumab plus cabozantinib compared to sunitinib in patients with untreated advanced renal cell carcinoma. Total of 1,200 patients were included who had no previous systemic therapy for the disease. Overall survival was significantly improved in nivolumab group compared to sunitinib, and there was substantial progression-free survival with the survival of 16.6 months for combination group versus 8.3 months for sunitinib. Safety profile The combination was associated with manageable adverse events, including hypertension, fatigue, and diarrhea. CATSTs. GCT-AC trial. It was published in 2024 to investigate the role of circulating tumor DNA monitoring and guiding the treatment decisions in patients with germ cell tumors. Patients underwent DNA analysis during treatment to assess response and guide therapy adjustments. And primary endpoint was rate of treatment adjustment based on circulating tumor DNA results. Sample size was approximately 250 patients. And inclusion criteria was patient diagnosed with germ cell tumors. 40% of patients at treatment modified based of circulating tumor DNA results, which correlated with improved outcomes. And early results suggest improved overall survival in patients whose treatment was adjusted according to the circulating tumor DNA monitoring. Adverse effects are similar to standard protocols. Thus, this trial highlights the potential of circulating tumor DNA as biomarker for guiding treatments decisions, enabling more personalized medicine. Overactive bladder. To evaluate the effect of transcutaneous electrical nerve stimulation device in managing overactive bladder symptoms. Primary endpoint was change in bladder diary parameters after 12 weeks and quality of life assessment. In arm A, patients were given TENS device and arm B was placebo device. 350 patients were included diagnosed with overactive bladder. Findings with bladder diary parameters, the TENS group reported significant improvements in urgency and frequency. Quality of life scores also improved, and it had minimal adverse effects. Thank you.
Yes. So we all know that it's important to understand the recent drug trials and the clinical trials that has happened in last few years, because they have been path-breaking. They have changed the management of urological problems, particularly uro-oncology. It may find a little boring, but still, I think as a trainee and as a student of urology, you should know all these trials, and they are important from the point of view of examination also. When we talk about uro-oncology, prostate cancer, the most important probably these developments in uro-oncology has been immunotherapy. The immune checkpoint inhibitors, the PARP inhibitors, the TKIs, which have changed the management considerably in the last few years. In prostate cancer, he talked about the ERA-STEP trial where darolutamide with androgen deprivation therapy has become an important option in hormone-sensitive prostate cancer metastatic. You didn't mention about the magnitude trial, which again has a niraparib and abiraterone in metastatic CRPC. And then there is an EMBARK trial also, where enzalutamide, you talked about the profound PROSPER trial. But later, even the EMBARK trial also proved that enzalutamide plus ADH is probably the standard of care in hormonal non-metastatic CRPC in prostate cancer. When we talk about radiotherapy, there has been a newer device which is called BioProtect, which is a balloon implant system which is put in the rectum, which helps to prevent rectal complication during radiotherapy. So when we talk about RCC, previously there was no treatment, then the TKIs came, and now we have immunotherapy. So most of the studies have proved that either immune checkpoint inhibitors or a combination of ICI plus TKI is the standard of care in metastatic RCC. So they have a trial called Cosmic 313 trial, where cabozantinib with nivolumab plus ipilimumab has been shown to be beneficial in advanced RCC. Then there was a clear trial where livatinib plus pembrolizumab has been shown to be of benefit in advanced RCC. And then the patients who have been associated with VHL, particularly, there is a drug called belzutifan, which is MK6482. This is a HIF2 alpha inhibitor, is found to be of beneficial in patients of RCC with VHL. When we talk about CA bladder, again, the major studies which have proved that in metastatic prostate CA bladder, we had chemotherapy as the standard of care, but now they have shown that immunotherapy as immune checkpoint inhibitors, either alone or in combination, could be used as a first-line therapy in metastatic CA bladder. So we have various trials. You mentioned probably of EF302, which is enfortumab plus pembrolizumab in locally advanced and metastatic CA bladder. Then the Checkmate 901, which combines nivolumab with ipilimumab in metastatic urothelial carcinoma. Then there is a IMvigor trial 130, which combines atezolizumab plus chemotherapy. So basically, either you combine this immunotherapy with CT or even alone immunotherapy as the first line of therapy, those patients who are not fit for chemotherapy. Then we have Thor trial where erdafitinib has been used for metastatic urothelial carcinoma, particularly where there is an increased, where we have been, there are a lot of studies with showing various biomarkers which tell you about the various severity and the grade of malignancy. And when there is an increased fibroblast growth factor receptor, then this erdafitinib is very useful. When we talked about testicular tumors, we talked about the role of CTC, right? Besides this, there have been a study called PRIME test, where they have shown that even in stage 1 seminoma, adjuvant chemotherapy is beneficial. Then there's a TIGER test, where patients who relapse after chemotherapy in testicular tumors, a high-dose chemotherapy has been given, which has shown to be beneficial. When we talk about andrology in urology, subspecialty, then in male infertility, there has been certain studies which have shown that use of GnRH analogs and antioxidants might help in improving semen parameters in those patients who are put on radiotherapy and chemotherapy, particularly patients who have testicular tumors. In patients of erectile dysfunction, there are a lot of studies in low-intensity shockwave therapy, then platelet-rich plasma and stem cell therapy, and gene therapy, and also various newer penile implants. When we talk about overactive bladder, urinary incontinence, he talked about the tibial neurostimulator. There has been a study called OASIS trial, where they have used this Revi system, which is a tibial nerve neurostimulator. Then the newer B3 agonists like vibegron. Vibegron is coming up in a big way after mirabegron. This is the EMPOWER trial, where they have shown that this is helpful. Then we have a lot of trials in Botox injection, those who are patients who are refractory, overactive bladder, and the sacral neuromodulation devices. Now we have InterStim device, which is can be recharged. We do not have to replace it. So the new InterStim device is there. When we talk about urolithiasis, there is a product called nidoceran. Nidoceran is being used for treatment of primary hyperoxaluria. So this helps to treat my type 1 primary hyperoxaluria. And thiazide diuretics and allopurinol are being given more often nowadays, patients who have calcium oxalate stones. And with those, we know this calcium oxalates often are a combination of uric acid followed by calcium oxalate deposition. And then in shockwave lithotripsy, there's a new machine coming up, which is a burst wave lithotripsy, where the acoustic waves are being used to fragment stones. So this burst wave lithotripsy may be useful, and the patient do not require any kind of anesthesia. It's almost painless. So this may be a newer kind of a device, which is when you talk about non-BCG responsive, non-invasive bladder cancer, there is a drug called nadofaragene, which has been used for patients who are not responsive to BCG in non-muscle invasive bladder cancer. I think that was in short about the various studies which have been done in last few years. And now we can take up the questions. Yeah. So the question number one is, which drug was used along with radiotherapy in taxinergy trial for advanced carcinoma prostate? Cabazitaxel, enzalutamide, nivolumab, pembrolizumab. Cabazitaxel. So he discussed about the taxinergy trial where cabazitaxel was used along with radiotherapy, right? So which of the following drugs are used in patients with non-metastatic castration-resistant prostate cancer? So there are a lot of trials. One is he talked about the PROFOUND trial and the EMBARK trial. Both trials prove that enzalutamide is probably the standard of care in patients with non-metastatic CRPC, right? Which of the following drugs combined with cisplatin and gemcitabine showed improvements in patients with MIBC? Which of the following drugs combined with cisplatin showed improvements in patients with MIBC? Muscle invasive bladder cancer? Okay, as a neoadjuvant, you could say? Huh? Avelumab. Avelumab is being used for metastatic CA bladder, not as a neoadjuvant. So whatever it is. So a combination of immunotherapy and chemotherapy or alone immunotherapy is becoming this new treatment option in metastatic bladder cancer. So avelumab, the Invictus trial, suggested that combining in the standard chemical could enhance the response rates in MIBC, paving the way for future studies. Yes. TENS, the transcutaneous electrical nerve stimulation device, is used for management of ICBPS, overactive bladder, neurogenic bladder, ED. So overactive bladder. So TENS is used being quite more often. We know TENS was used decades ago, but now this is again being come in with different studies that they are useful. So as I said, there are a lot of trials. There's a machine called eCoin where they put this under the skin subcutaneous implant. It doesn't require any electrodes. And this tibial neurostimulation can help in patients with overactive bladder, particularly refractory cases. So circulating tumor DNA monitoring is used in guide of treatment patients with bladder cancer, testicular cancer, prostate cancer, and renal cancer. So he talked about that study where it is used in testicular cancer, right? So thank you. Thank you very much. Anybody from the resident side or the faculty side would like to say anything? Yes, you want to? Before anybody, yes, please go ahead.
Endpoints, some talk about overall survival, some talk about progression-free survival, some talk about radiological progression-free survival. And sometimes this is overall effect, the benefit is for a few months only, like 5 months in trials. And how do we merge the adverse effects of the drugs that are given sometimes, they say that more than 30% have grade 3 adverse effects.
So, Dr. Pashasi, our resident had a question regarding the various studies which have been done in uro-oncology, particularly prostate cancer. The endpoints have been different. Some studies have overall survival, some have radiographic progression-free survival, some have biochemical recurrence. So, how do you actually equate these studies and try to see which is better? Plus, many of the studies do not say about the adverse effects and the quality of life in these patients who have been put on the various drugs. So yes, it's a very important point that you have raised. And definitely we need to balance between the adverse effects plus the benefits of these drugs. Plus, as you said, the benefit is usually few months. This has been there on most of the studies. Even if you have a extension of a few months, they consider it quite significant. So again, this is a kind of a debate whether for benefit for a few months, would you like to put the patient on that much of a financial burden, or the adverse events that can also happen in these patients, should it be given to now? So that has to be decided by the clinician who is treating the patient. I think that depends upon many factors, right? It's financial and ethical and moral and patient, doctor, what does the patient actually want? So I think we would not go into that debate. Yes, but yes, the endpoints, if they are similar, then definitely it tells you about that this is probably could be the standard of care. Yes. Anybody else? Right. So if no faculty, no residents has any question, I would request the moderator to kindly wrap up the session, and then we will just conclude this.
Thank you, sir. My question from the resident is, Dr. Karan has mentioned in the trials, there are different phase 2, phase 2nd. So what do you mean the phase 2 and phase 2nd? What are the different stage of the trial?
So anybody has an answer to what are the different phases of trial? When we do a clinical trial, there's a phase 1 trial, phase 2, phase 3, and phase 4 trial. Anybody knows exactly what does it mean? I think this is a very simple and basic question. Yes, go ahead. No, it's just, why do you start from phase 4? Why don't you start from phase 1?
Safety of the drug, phase 2, the efficacy of the drugs. Phase 3, the trials are done pre-market analysis, and phase 4 post-market analysis.
It's not a don't say pre-market analysis. So don't put market everywhere. So first, yes, phase 1 trial is usually to understand the clinical and the adverse events, whether this particular drug is, it's usually a pilot study. All these are phase 1, phase 2. So where they see the adverse events, and secondly, whether the drug is efficacious or not, as a pilot study. The clinic and the phase 3 is actually clinical trial, which is done usually a randomized controlled trial where you do it in humans definitely and try to find out whether this is beneficial or not. And the phase 4 is usually the post-marketing when the drug has already come into the market, and then you try to do a study on their adverse events, etc. Yes, do you want to say anything?
One thing I want to add, post-marketing trial is a phase 5. Phase 4 is the long-term efficacy of the particular drug, long-term effect, and the phase 4 trial. Yes. Thank you, Dr. Karan, for nice presentation, and thank you, Shivam sir, for giving valuable inputs on the different trials, and thank you all faculty member resident who join us.
I think thank you everybody. And thanks all residents, faculty members, and all those who might have joined us today on Zoom and YouTube. Thank you. and have a good day.